Operating a healthcare facility without a unified system guarantees administrative friction. Departments create siloed protocols, and revenue cycles leak, and clinical errors compound in the gaps between overlapping workflows. An effective accreditation standard forces those overlapping workflows into a highly aligned, predictable structure. The National Accreditation Board for Hospitals and Healthcare Providers, or NABH, was established in 2006 by the Quality Council of India, precisely to address this systemic industry chaos. It laid down the foundational benchmarks for national healthcare, creating an authoritative standard that dictated exactly how a hospital should govern its clinical and administrative processes. Because of the strict oversight required to meet these benchmarks, hospital administrators often view the process as a regulatory penalty. They treat the standards as a punitive audit that must be endured. Implementing NABH standards bridges the gap between clinical safety and administrative profitability. It forces departments to communicate, which reduces errors and accelerates billing cycles. Full accreditation acts as a strategic business architecture. It provides the operational redesign required to move beyond basic compliance checklists. This diagram shows the underlying structure of a functional hospital system. It relies on 6 specific, interconnected operational pillars to remain stable. The bedrock of this entire framework is Pillar 1, patient safety. Every administrative protocol begins with ensuring the physical protection and predictable care of the patient. Securing that safety directly connects to Pillar 6, risk mitigation. By standardizing care protocols to protect patients, a facility reduces its malpractice liability and legal exposure. Clinical consistency also governs the financial side of the institution. Standard operating procedures dictate the speed, accuracy, and efficiency of your billing departments. This operational standardization defines Pillar 2, revenue. By establishing strict, repeatable workflows, you optimize the revenue cycle by filtering out administrative waste and rejected claims. Those workflows require competent execution, bringing us to Pillar 4, staff management. Clear protocols give your medical staff a defined scope of work, improving training efficiency and retention. With clear scopes of work, staff can identify process flaws without facing burnout. This establishes Pillar 5, continuous improvement, creating feedback loops where frontline workers constantly refine the system. When these 5 internal pillars function systematically, they produce a final external result. Pillar 3, trust. Market reputation is the logical outcome of mastering the other 5 internal pillars. Failing in any single pillar compromises the stability of the entire organization. A lapse in safety risks legal exposure, revenue loss, and staff attrition simultaneously, making the complete framework essential for survival. The transition to the NABH 6th edition standards changes exactly how this systemic quality is measured. This graphic compares the 2 methodologies. On the left is the legacy, process-based model. It relied on rigid, exhaustive documentation rules to prove compliance. Under that old system, administrators spent an inordinate amount of time verifying how every process was recorded, creating a documentation burden that slowed down daily operations. The 6th edition introduces an outcome-focused model, replacing the paper trail with data-driven performance metrics. Instead of checking if a policy was simply written down correctly, the new standards prioritize measuring the actual clinical results and infection data the hospital produces. To facilitate this, the framework consolidates the previously sprawling list of annexures into a streamlined structural format. This reduction in redundant paperwork removes documentation bottlenecks, allowing medical staff to redirect their time back to actual patient care. The 6th edition shifts an administrator's primary job away from managing compliance paperwork, tasking them instead with optimizing actual clinical data. For an executive choosing a compliance path, the market offers a fragmented landscape of quality standards. This comparison matrix maps out the 3 dominant tiers of accreditation available to healthcare facilities. On the left is entry-level compliance. This is the absolute baseline regulatory requirement necessary to legally operate a facility. While legally necessary, entry-level certification lacks the operational depth required to reduce waste or drive maximum revenue generation. It keeps the doors open, but it does not optimize the business. On the far right is JCI, the international gold standard critical for medical tourism. However, its implementation cost and operational complexity create a friction that is unnecessary for most domestic hospitals. Sitting directly in the center is full NABH. This represents the optimal efficiency frontier, balancing national excellence with a practical implementation cost to ensure local market dominance. Full NABH provides the highest operational return on investment, securing clinical reliability without the high costs associated with international tier compliance. We can move past theoretical frameworks and look at empirical data to evaluate the exact efficacy of the 6th edition standards. In a recent case study, a mid-sized facility was dealing with severe operational bottlenecks. Patient discharge times were averaging over 6 hours, and inventory shrinkage was consistently high. Prior to NABH implementation, these administrative failures were causing a 14% drop in quarterly revenue and a spike in post-operative secondary infections. This data dashboard tracks the post-accreditation efficiency metrics. Within 8 months of compliance, average discharge times fell by 60%, and inventory waste was nearly eliminated. These process improvements translated to revenue enhancement. The facility recorded an 18% increase in billing cycle speed, capturing capital that was previously lost to administrative error. Looking at the patient safety metrics, the standardization of surgical protocols dropped the post-operative infection rate by 42%. The case study demonstrates that the initial operational friction of achieving compliance is balanced by the resulting institutional leverage and long-term savings. Transitioning from evaluating the data to executing a practical organizational rollout requires a precise diagnostic phase. This diagnostic checklist outlines the core operational indicators that signal a facility is ready to pursue full accreditation. It requires existing baseline documentation and a fully staffed quality control team. Executive intent is not enough. The primary hurdle to implementation is that accreditation demands strict, phased project management across every department simultaneously. To manage this, administrators must deploy specific structural tools. These include a comprehensive gap analysis template, a 12-month Gantt chart for timeline management, and a master compliance checklist to track daily progress. Utilizing these tools to master the NABH framework strips away administrative chaos. It transforms a hospital from a reactive clinical space into a proactive, highly optimized business engine.